So this evening we have Dr. Kinga Kisko. She received her Doctor of Osteopathic Medicine at New York College of Osteopathic Medicine, followed by her residency at Jamaica Hospital Medical Center and fellowship training in both geriatric medicine and hospice and palliative care at Northwell Health System. And Dr. Kisko's practice is located in Glen Rock. Welcome this evening. Thank you for joining us, Dr. Kisko.
Hi, thank you. You can hear me okay?
Yep.
Hi, everyone. So thanks so much for joining for this talk. I have to say, I was really excited to give it. I think, I'm coming into outpatient primary care and geriatrics after being in the inpatient setting for many, many years, both clinically and academically in the hospital-based setting. So there's a lot for me to learn, and so part of the reason why I was really excited to accept this talk was because I am very passionate about preventative care, longevity, primary care, and care for older adults. I'm very passionate about fighting ageism and just promoting the most incredible quality of life and healthcare and the longest life for all adults. And I'm an ally, and there's so much for me to learn. And I am so happy to be speaking to you today. So what we're going to talk about today is we're going to talk about aging through the LGBTQ plus lens. So we are understanding that life experiences and history and social structures shape our health. They shape how we age. And this talk is meant for all individuals, people that are older adults who identify as LGBTQ plus, caregivers, allies, anyone interested in learning more. There is so much time that I can dedicate to this topic. So in preparation, I think, oh man, we're going to have follow-up presentations in the future. So I'm hoping that I'm able to give this topic justice. Okay, this very important topic. So I'm always learning too. And so I did so while preparing for this talk.
Just so Dr. Kisko, sorry to interrupt. Okay, there, I was going to say we're seeing your notes, but now we don't
Yeah,
see them anymore. You're good. Thanks.
we're good. Good. So no more notes.
Correct. Yes, you're
Okay.
good. Thanks.
Let me know if this happens again. So why talk about LGBTQ plus aging? And these are some statistics, and these statistics are actually from a survey. The survey was implemented, across 47 states in the US between August 2023 to May 2024, reaching over 1,000 individuals aged 50 plus. And the average age of respondents was 67, and these were LGBTQ plus adults. And these are some statistics that I thought were important to mention. Almost half believed that their healthcare providers could benefit from additional training. 78% were concerned about access to care. And this was really prevalent in rural areas. 4 out of 5 reported fear due to the political climate. 1 in 2 reported isolation. We'll talk about isolation a little bit later. 50% reported being married or partnered. And I think about that, especially as we age, and how much our partners play a key role during our healthcare and overall well-being throughout different parts of our lives. 65% did not have children. And so again, children are, those people who are going to, care for their parents as they get older. 30% are caregiving, and 77% are concerned about caregiving for loved ones as they age. And I think a lot about those who are in the caregiver role, whether, regardless of how old they are and who they're caregiving for, and, whether there's somebody who identifies as LGBTQ plus and is caregiving for somebody who's not, or the other way around, and what are the resources for those individuals and how comfortable do they feel about seeking them and talking about their specific struggles during their caregiving journey with their healthcare professionals. Financial security is a worry, and another one is finding a provider who is going to be comprehensive in their care. And so these are some statistics that led me to be a part of this talk. Okay. And then I also, there were also really wonderful statistics that I was reading when I was reviewing the survey, is that the LGBTQ plus population is just really interested and really willing and wanting and already very involved in their community into forming intergenerational relationships. Into, there's a lot of involvement within religious organizations over the last year, as reported in the survey. And also, almost half of the people reported being involved with advocacy, organizing, and mutual aid, which I think is really, really wonderful. And so, who are these adults that I'm talking about? And so, these are people that identify as lesbian, gay, bisexual, transgender, queer, questioning, and plus, right? And so, these are people that represent, all races, cultures, religions, and backgrounds across every area of the country. And something that I'm seeing, and even as I'm paying more attention across my patients' charts, right, and I'm thinking about demographics, is that many will not disclose their identity in healthcare settings. And that's for, a lot of reasons. I think a big part is, it's a protective decision based upon past discrimination or harm, So, people will selectively disclose. So they may not disclose, to the person, initially as they're getting into my room or their healthcare provider's room, and then hopefully will feel comfortable to be able to disclose their gender identity to me. And historical context really matters in this. And if we're thinking about it, was only in 2015 when same-sex relationships were legalized in this country. And in the 70s, the DSM, which was this big manual for psychiatric illnesses, had labeled LGBTQ plus identity as a mental illness. And there is a fear of loss of employment. There are limited resources and support services and laws protecting individuals, housing, families, and also thinking about how the HIV/AIDS epidemic devastated a whole generation. And this is something that came up again when I was working at Mount Sinai as a hospital medicine physician during the COVID pandemic, and everything that went on during that pandemic and how isolating it was and how people were treated, where I have to say that there was a lot of trauma, a lot of PTSD that came up about with regards to people who have lived through the HIV/AIDS epidemic in the 80s. And so how does history affect health today? Well, depression is something that if anybody has ever been to see me in my office for primary care knows that I spend so much time about mental and spiritual healthcare maintenance. And a big part of that is because I strongly believe that the mind, body, spirit, all of those things play, a key role in your overall health. And so if you have something like 30 to 40%, which I'm sure is underrepresented in this number, and how that will interplay, how having depression, depressive symptoms will then impact your overall health. There's higher anxiety, PTSD, and substance use rates. I always say, for example, alcohol, the most common comorbid condition, which as with regards to mental health, that does predispose us to using or abusing alcohol is anxiety, untreated anxiety. And alcohol is a toxin. Many people delay or avoid healthcare. I mentioned that before, and a big part of that is just fear of being disrespected, fear of being mistreated. And also senior housing. There's something I'll talk about later briefly, but then there's this fear of needing to come out for the second time. So you have individuals that have been within their community, and were able to come out in their identity within the community, and now they're entering a senior housing community with a whole new array of people around them, and may feel like they need to hide, their real identity because out of fear of not being accepted or being discriminated against. And this is huge, especially when planning for the future, or as abilities to be able to stay at home or, change with increasing, change in age or functional or cognitive abilities. So what does affirming care look like? And I have a plug here for the Valley Center for LGBTQ Care, which is, this comprehensive range of services in primary care that are offered through the Valley Hospital, including gynecologic services, sexual health, HIV testing, HIV treatment, adult transgender care, and behavioral health. It's a wonderful, wonderful resource here at Part Valley Hospital. But this is essentially asking, us as healthcare practitioners, for any healthcare practitioners in the audience, just asking, not assuming. And there are ways to do that, and we can talk about how to do that. Respecting names and pronouns, and that can be also done. Something that we're implementing in our office is, some of us are going to, choose to display our pronouns on our IDs and just show that we're people who are strong allies, and including families of choice. The CARE Act, this is something that I saw a lot when I was working in hospital medicine, right? Like, is that we always ask at time of admission, and sometimes this is scary, especially for people that are coming in for symptoms or being admitted for illnesses that are not, necessarily life-threatening. When, one of the biggest questions, or the first questions I used to ask on admission, is if you were not able to make healthcare decisions for yourself for whatever reason. Was it, infection, medication, exhaustion, and you're not in your clearest of mind? Who would be the person that would be making healthcare decisions for you? Because, for example, in New York State, where I was working, there's, if you do not have an appointed healthcare proxy, there is an order of surrogacy, the Family Healthcare Decisions Act, and this is different across different states. But it does then, force physicians or to contact appointed people based upon, your either, immediate living environment or your, blood relation to someone. But that may not be a person that you want to be making your healthcare decisions. They might not be someone that is even aware of your healthcare needs. And that's why, if you're ever in a hospital or you're ever in any care setting and you are being asked that, I know it's scary, but none of us really know when we're going to lose our mental, status for whatever reason. Or we might get tired, we might get confused. We're getting anesthesia for a surgery or procedure, and we want there to be somebody, as your physicians, that will be making your medical care decisions based upon what your preferences are and what your voice would be. And so another thing that I think is so important then to talk about is, what are some of these medical issues that are seen more often across across patients that are LGBTQ plus. And I think, and this is something for me to consider and for your healthcare providers to consider when they're seeing you in the office, and also something for people to consider in the community, is higher risk for cardiovascular disease, certain cancers, and cancer screening guidelines is something that I am going to discuss, and I'm going to give individual slides to, because again, preventative care is something that I am so incredibly passionate about. HIV is a chronic condition, and that also includes folks who are initially, decades ago, were using some of the older HIV drugs, right? And so are now suffering with side effects of those drugs. And another one is osteoporosis. And I'm going to briefly talk about cognitive decline, what that may look like, and special consideration with respect to cognitive decline. So cardiovascular health, this is something that's really important. Cardiovascular disease is, a leading cause of, chronic healthcare, chronic disease in adults, right? And I think what's really important is something, again, at least annually, right? But seeing your physician, and especially after the age of 50, right? Regular monitoring of blood pressure, lipid profiles, hemoglobin, and hematocrit. Because I'm talking about 50, this is something that I've recently been extremely vocal about in my clinic, and I'm going to put it here just for patients who are joining, is specifically for memory care and prevention of developing memory disorders. I think at around the age of 50, it is important to consider getting a hearing test, ensuring that you have good sound hearing, because how our brain is able to hear environment is really important for how we're going to process it and how we're going to form memories and networks. And so again, so this is good for cognitive testing. But so why is blood pressure, lipid profile, hemoglobin, hematocrit important? And I think what's, and you may have been in other lectures, or you may be, again, healthcare professionals. So yes, like we do need to make sure that our blood pressure stays controlled, whether depending on what your blood pressure cutoff is, and cholesterol. But specifically when it comes to transgendered individuals, if you're in gender affirming hormonal therapy, this may increase cardiovascular risks. Sometimes I'll see people on estrogen therapy for many different reasons. And thinking about my adults that are older adults in estrogen therapy, I think about what type of estrogen therapy and how they are receiving it, right? There is studies that indicate that there is an increased risk of venous thromboembolism. Those are PEs, pulmonary emboli into your lungs, strokes, myocardial infarctions. And this is the longer you use, estrogen, the higher your risk. And especially if you're not using transdermal patches. And so some sources even recommend talking to your doctor if you are using transdermal, if you are using estrogen, is there any potential or any possibility to switch to estrogen that is transdermal? With regards to testosterone therapy, thinking about testosterone making blood thicker, more viscous. This is why I included regular hemoglobin hematocrit monitoring, because when your blood is thicker, when it's more viscous, you are going to be at higher risk for strokes, clots, etc. And this is something that I'm going to spend the bulk on is preventative health screening. And this is, again, something that, depending on which guideline you're listening to, and there's the USPSTF, the American Cancer Society, the American Radiologic Societies, right? Thinking about what type of healthcare screening am I going to ask my doctor for? And there are actual, like Sage will have actual checklists that you can obtain and print and see, whether my doctor is doing all the correct screenings. But I think the most important take home point with this is that we need to obtain and we need to ask our doctors, and also think when we're seeing our patients, obtaining the right screening for your body, and your risk factors. And so thinking about what are my body parts and what are my risk factors for developing cancer, irrespective of what's my gender identity. I'm going to start with breast cancer screening. Breast cancer screening is controversial. I've always gone by the American College of Radiology guidelines, not the USPSTF. Primarily as a geriatrician, I feel there are differences in age cutoffs and screening. What I would say is, for my patients, again, I individualize therapy. Sometimes people will stop screening at 75, and oftentimes they won't. And oftentimes I'll encourage them not to, right? But thinking about my LGBTQ individuals, and thinking about transgendered individuals, trans women who are male sex at birth, thinking about, okay, should I be getting mammograms? And I think that depends on your estrogen exposure. Sources say, and sources differ, but general rule is 5 or more years of estrogen exposure, you should be starting annual screening at 40, like all women do. And you might even consider to start earlier, whether there's any family history of breast cancer, BRCA mutation, or if you've had high dose or a long course of estrogen exposure, breast cancer screening is something that you should start getting. Similar to trans men, female sex at birth, then that will depend on whether you had a mastectomy or not. If you've had no mastectomy, you will have your annual screening begin 40. And if you've had a bilateral mastectomy, understanding that there still may be some residual breast tissue. And so clinical chest wall exams, breast exams, should be done. And then we can decide whether we're going to get MR or ultrasound, depending on what we find on the chest wall findings. Okay. But so again, these are individualized. Moving on to cervical cancer screening, I did include guidelines from USPSTF as well as the American Cancer Society. And for all individuals, right, 21 through 29, pap smears every 3 years. 30 to 65, there's different things that you can do every 5 years or every 3 years. Um, Generally, at age 65, if your prior tests have been consistently normal, you can stop cervical cancer screening. And this will include, trans males who have a cervix. And so this is something that we should ask as providers, and something that I hope people feel comfortable telling providers. And very similar with prostate cancer screening for trans females. If there is a prostate, and if you have a prostate, prostate cancer screening begins in the 50s, and that is, depending on how often we continue it, or beyond, your 70s, again, depends on risk factors. But this is one area where, if you're on gender affirming estrogen therapy, that will lower PSA levels. And so ensuring that your primary care provider, urologist, is aware of LGBTQ plus health, because that's how they're going to, be able to interpret PSA levels within the context of getting estrogen therapy. Osteoporosis screening is something I'm really, really passionate about. I think that, I think that in general, it's, fractures of any sort, are life altering, and at times can even be life limiting. My good friend and social worker in practice, Jennifer Fiore, will say nobody wakes up in the morning, thinking or planning to fall. And if you have osteopenia, osteoporosis, you're at such higher risk for getting that fracture, even from a minor fall. When it comes to, I want to speak here about like transgender people specifically, because bone density screening, I think, should begin like everybody else at 65. But one of the things to think about is risk factors for osteoporosis, or elevated risk factors for osteopenia. So people who have undergone gonadectomy and have a history of at least 5 years without hormone replacement, regardless of age, should receive bone density screening. And part of the reason we say that is because when it comes to cisgender males, we're not always recommending screening for bone density. It depends on your risk factors. And the modality of screening, usually what we do is we use, we'll recommend DEXA. There's different ways to screen for osteoporosis, but DEXA is what we're using. And that's of the hip and lumbar spine. And then how often we screen, well, that's going to depend on your risk factors. And it's also going to depend on those results. And so this is something to discuss with your healthcare provider. Osteoporosis screening is something, again, I'm extremely, extremely passionate about, because we don't feel necessarily that our bones, that we're losing bone mass, right? We don't feel it. And oftentimes that initial fracture is how we know that we've lost bone mass. But by then, we're in a lot of pain, or we may be facing some disability. Colorectal cancer screening beginning age 45, right? And frequency is individualized. I want to say something, and this is just for healthcare professionals in general, is just understanding that in studies, transgender individuals are going to have lower rates of cancer screening compared to cisgender. And that has a lot to do with just not feeling safe within the healthcare setting to disclose identity. And so for this reason, I'm just trying to really stress the point, home in on the fact that as medical providers and healthcare providers and offices, we really need to be providing inclusive care and be open about it, and be understanding, and create really good rapport with our patients so that we can foster honesty. And that means, we need to spend time to get to know our patients during our visits, and build relationships and see people at least twice annually, right, or more often if needed, but become big, collaborators in healthcare. For caregiving challenges, these are some questions that I want you to ask yourself, because this is a really big topic that, and this again used to come up to me when I was working in the hospital. Who helps us when we're ill? Who makes our medical decisions? Who provides our daily care? And thinking about some of those initial statistics that I had mentioned at the beginning of this talk, about statistic with regards to marriage and partnership and children. And then there's this whole topic of chosen family, right? When our own, immediate family, the family we were born into, may not be our safest point of contact, or may not be someone that we even communicate with still, understanding that throughout our life, we may have formed close relationships and friendships. And many of you have people in your lives that you consider, a brother and a sister that are not a blood relative. And so, um, you know, there are healthcare disparities, that we have to be aware of. And it just as a community, I hope be able to come together and address both as a community, the medical community and beyond. And this is where advanced care planning comes into place. A healthcare proxy and a living will, these are legal documents. These are drafted by an individual who is a lawyer. At the bottom, I have a link to some of the resources, the National LGBTQ plus Bar Association, where you can actually have access to LGBTQ plus informed legal care. But having these things in writing is really, really important. Naming trust and decision makers is really important. Illness and time of illness and time of hospitalization is particularly stressful for everybody, for family, and multiple times when it comes to asking for assistance with healthcare decision makers making, if there isn't something formally in writing, either your healthcare professionals will make your decisions for you, or your healthcare professionals will reach out to individuals that are, known to you or within your family that they have access to, or, and so appointing someone and putting that in writing can also help during this is a time that can be also very particularly dividing to families when there is advanced illness or critical illness. And people may have different, and oftentimes do have different opinions of what is the next course of action. And so understanding also that a living will, well, it's a legal document, it's not a medical document. This is something, this is a document where you can disclose your preferences regarding your critical care, your life-saving care. This is like your intubation, resuscitation, et cetera, nutrition, hydration. But knowing, like in many states, for example, in New Jersey, there's actual forms like, the POST form that are forms signed by physician that are actual medical orders to be able to carry out those decisions for you. Because, if you do not have an actual POST from a medical order and EMS comes to your home, they're going to do sort of everything that we are algorithmically and systematically do to save life, regardless of what your preferences may be in your living well. Naming trusted decision makers is really big, and also letting them know that you've named them to be your decision maker. And this is actually part of the CARE Act that I spoke about before, is that, and a lot of the times we'll do that in the office. I'll say, do you have a healthcare proxy? And somebody will tell me, yes, it's so-and-so. Then my follow-up question will always be, do they know that they're your healthcare proxy? And have you had these intimate conversations with them? Because the decisions that we'll be asking them are going to be really, really big. I also did some research into Medicare considerations. I was pleased to see that there were good resources on the Medicare.gov website. I was thinking about, options in Medicare, especially when it comes to individualized needs. This is where prescription medicine comes into play, gender affirming surgery, and whether Medicare is going to cover and pay for those things. And the answer is yes. And I think it depends on your plan. And there is a Medicare plan finder. There's the Medicare and You handbook, and Medicare.gov has the Medicare plan finder. And this helps you find assistance in choosing your coverage. And federal law does protect individuals from discrimination based on sex by healthcare providers, right? And if you ever feel like you've been discriminated against, there is Justice in Aging. This is a really wonderful resource and website where it's a whole firm that advocates for exactly that, for justice in aging, or any sort of and can provide assistance for individuals that feel like they've been discriminated against and need some support. A little bit about dementia and dementia care. I know that this has been very wordy, and I want to be able to spend a good amount of time in discussion. So I promise I'm hoping I'm able to keep everybody engaged. Dementia and dementia care is profoundly important. And I also want to mention that there has been a lot of incredibly exciting developments in dementia and dementia care and prevention. But part of the reason why there may be higher rates of dementia in the LGBTQ plus population is because there are higher rates of conditions, or even whether they're medical or environmental, that predispose you to developing dementia. Be that social isolation, limited family support, discrimination in healthcare settings, all those things. Again, isolation, limited family support, and loss of access to preventative healthcare for all of us increase our risk for dementia, for incident dementia, which is dementia development or dementia progression if it's already present. And 29% more, so LGBTQ plus individuals are up to 29% more likely to report memory loss than heterosexual counterparts. And it is essential for healthcare providers to include families of choice, as is essential for people, if they do have families of choice, beyond their blood relatives, to be able to have that written in writing, because there's going to be a period of time where, and oftentimes in the office, we include your network, your support network, and care planning with regards to your medical care, but also with regards to your safety and where you're going to live. And this is, I briefly touched on that before, is especially when, choosing, senior housing, long-term care, are these places that are going to be friendly and inclusive, and places that you're going to be feeling comfortable in. And so hopefully somebody who is helping you choose them is aware of that and is aware of needing to ask that, because of that fear of double coming out, right, in healthcare settings. There's also this likelihood to live alone and less likely to have children to act as caregivers, and then if there are caregivers, they experience higher rates of stress, lower self-rated health, and higher disability rates. And this is just more important and just more testament to the fact of, the need for healthcare settings to be able to provide support or link you with support and resources. Because isolation is a health risk. Loneliness increases mortality. And I'll always say loneliness is experiential. You can be surrounded by so many people and feel incredibly, incredibly alone. New York City is a really big example of that, right? So, and it does lead to an increased risk of dementia and depression. Finding community support is crucial for health and longevity. And so I found a website within Bergen County that I wanted to provide you guys an address to, and that's where there are resources that are available to be able to link you with a community. Because, and especially, and many of these are virtual, and I'm thinking about really, really cold days like this where leaving the home is difficult. Tips for finding mental health care. So this is something that I think was really neat. There are specialized databases, the Association for LGBTQ Psychiatrists, Inclusive Therapists, the National Queer and Trans Therapists of Color Network, checking insurance filters. And this is something that you can do even if you were to use websites like Psychology Today, like checking filters for people that are LGBTQ plus informed. Interviewing potential providers, actually asking, about their competency, when LGBTQ plus care. Ask about experiences with their approaches to care, and comfort. Considering telehealth, especially in places where mental health is limited, and looking for affirming signs, whether it is, something that, provider bios are often affirming, language or indicators, including pronouns, etc., pins that you may see on your provider's jackets, and checking for group therapy in some because that can sometimes be more accessible, more affordable. So what can older adults do? We can begin with bringing a trusted person to visit, which is for all adults, including myself when I go and get my, healthcare physical, is bringing somebody who I really trust to be there in the room with me. It doesn't have to be for the entire visit, but at least for a good beginning or closing of the visit so that both that person is able to become comfortable with my primary care physician, but they can also hear some of the things that I'm not hearing and also hear the many of the things that I'm saying. You want to advocate for preferences. Advanced directive completion is crucial. And seeking affirming providers. And what can we do as allies, as caregivers, is we can listen without correcting. We can show humility, respecting identity, respecting privacy, providing help with planning paperwork, and speaking up against discrimination. So the key takeaways from my talk is that challenges are real. Planning protects dignity. Affirming care improves health. And everyone deserves to age safely and authentically. So finally, I thank you for coming to this talk. And I have a list of some resources that are local within Bergen County. And many of these is where I received my information to be able to put this talk together. And if there's anything particularly within this very broad, rich topic that I can provide follow-up talks on, I would be happy to do so. Thank you.
Thank you so much, Dr. Kisko. We do have some time for questions. If anyone would like to ask a question, you can do that by typing it in the Q&A box located at the bottom of your screen. I think I personally had one question.
Sure.
And this is for any older adults. What does healthy aging look like to you? What do you consider as someone who's aging healthy?
I think that's a really excellent question. I think that's regardless of, and that is regardless of your numerical age, right? And I think, and that ebbs and flows. I think quality of life is what I think is the biggest predictor of healthy aging. And quality of life, can mean different things and means different things to different people. So I always explore that, but you can reach, incredible numbers, that are numerically high, but feel, not well, whether it's spiritually, mentally, physically, right? And this is why I love working in geriatrics, because I get to work with adults, across a huge spectrum of ages. So healthy aging for a lot of people, those that come to me, looks like being able to participate in activities that they enjoy, interact or be surrounded by family and friends, be relatively, and that can be completely always, but free from pain or distressing symptoms, or if any chronic diseases have developed, having them under control so they're not symptomatic. Healthy aging means being, feeling content within your own self, cognitively, functionally, whatever that may look like. But longevity is very much based upon your quality of life at whatever numerical age that you reach.
That was a great answer. And seeing that no other questions have come in, I think it is a great sentiment to end tonight's program on. So thank you so much, Dr. Kiska, for joining us this evening and for your informative presentation.